Hello, everyone. I'm Solomay Tibabu, your Going Digital Behavioral Health Tech Summit host, and I'm really excited to be here today with the Equip team. So before we jump in, why don't you go ahead and introduce yourselves?
Absolutely. Hi, everyone. I'm Kristina Saffran. I'm the co-founder and CEO of Equip Health.
Hi, everyone. My name is Erin Parks. I am Kristina's co-founder and the Chief Clinical Officer of Equip Health.
Awesome. You both have a wealth of experience with eating disorders and surrounding treatment. Please tell us a little bit more about your background and all of your experience in the last decade.
Sure, absolutely. So I always say, I feel like I've been working in eating disorders for my entire life. So at 10 years old, I was diagnosed with anorexia, which is young, but unfortunately not all that rare. And in my own recovery at 15, started an organization called Project Heal, originally to raise money for people with eating disorders who couldn't afford treatment. I learned early on that 80% of the 30 million Americans who suffer with eating disorders don't get treatment, and said, at 15, I'm going to solve this. And this was the way I knew how to solve it, raise money for people who couldn't afford treatment. Obviously have become more sophisticated, my understanding of all of the barriers to access as I've kind of grown up in this field. And I think really over the last decade, it's been so exciting to me to see that our research in the field of eating disorders continues to grow tremendously, and to know that we now have really good outpatient evidence-based treatments that work really well. And simultaneously, it was kind of horrifying to see that while the research got better, the actual treatment landscape and treatment quality got way worse. And so after, as I say, kind of 10 years of trying to plug holes in a broken system, I was like, you know what? I think I know the system that needs to exist, and I think we just need to build it. And Erin was the first person I called.
And I'm so glad that you called me. Yeah, so I spent the past 10 years in academia trying to solve the same problem that Kristina was trying to solve. It surprised me that about where I was working at UC San Diego at a faculty position there, that 40% of people were coming from out of town, out of state even, to get treatment with us. And we knew that after the parity law in the mid-2000s that many eating disorder treatment centers sprung up around the United States. I think now most of them are kind of owned by the same 5 or 6 PE firms. So there should be a center in everyone's backyard, I thought. Why are people traveling all the way across the state and sometimes from around the world to get treatment at UC San Diego? And the reason is that there's this huge difference between treatment that feels good and treatment that actually works. And people were finding that in their own communities, they couldn't access evidence-based treatment. So I had met Kristina, 3-4 years ago now, and we were helping her with Project Heal. So we were one of the centers that was offering free treatment to her Project Heal grant recipients. And her and I just kept trying to brainstorm how to fix this treatment access problem. And I kept thinking, if we just can educate people to be really smart consumers and to differentiate between evidence-based treatment and just treatment as usual, then maybe it would work. But we still weren't solving it. So I was recruiting Kristina to come get her Ph.D. with me at UC San Diego. And then after she got accepted, I let her in on a secret that Ph.D.s are a horrible return on investment. And she had this idea, and she's like, let's go private sector. Let's see what we can do with some proper capital and lots of smart people. And so we are building the solution that we've been looking for.
Wow, interesting. Yeah, I want to ask you a little bit more about that, because moving from nonprofit and academia to digital health startup land is quite the transition. But even before then, what exactly is Equip?
Good question. Equip is one of the first eating disorder telehealth companies that is really trying to build the new gold standard of eating disorder treatment. We're equipping families with the skills they need to confidently recover at home. It is a fully telehealth play, and we are partnering very closely with insurers to build out this new gold standard of care.
Coming from academia, what excites me so much is that, as Kristina had mentioned earlier, we've got some really outstanding treatments for substance use, for OCD, for eating disorders. And everything is having a really hard time of moving from academia into the actual community. And there's a lot of reasons why that is. I think one is academics. I blame myself and many of my peers who I love very much. We've done a horrible job of disseminating it. We ask people to spend a lot of time and a lot of money to become trained in an evidence-based treatment, which isn't accessible to a lot of people. And we also have done a poor job of talking to the people who actually live in the communities and say, like, what do the people who are in your communities, what do they need? Like, what are the barriers to doing this evidence-based treatment? And so that's one of the things we're looking at changing with EQUIP is finding a way to disseminate evidence-based treatment.
Mm-hmm. Fabulous. So yeah, going back to that earlier thought, you know, what's been your personal experiences with, you know, why make the transition? You know, why better to do this through a startup?
Yeah, it's a great question. And we could talk about this for a very, very long time. It's funny because I sat just over a year ago, I sat next to Samir Malik from Genoa Healthcare at the Yale Mental Health Conference, and I was sitting from the nonprofit sector and was asked the question of, like, you know, expanding access, particularly to communities who don't have access. Is this nonprofit? Is this for-profit? And I was like, for-profit healthcare, I don't believe in it. I've definitely changed my tune since then, and I think there are a couple of reasons. One, I'll just be frank, fundraising is very, very hard, particularly in the eating disorder sector. Eating disorder nonprofits collectively raise less than $10 million a year for something that affects 30 million Americans. And so, you know, I think we gave it a heroic effort, and I'm so glad that Project Heal is there to support folks who can't afford treatment. And I kind of decided, you know what, to create large scale systemic change, you know, we're not going to get there in the nonprofit sector. And frankly, I did not want to spend the rest of my career raising money, because that wasn't a great, that wasn't just a thing that I was enjoying very much. Beyond that, though, it was actually really interesting how this evolved organically. So Project Heal had built a program called Communities of Healing. It was the first real evidence-based peer support program for folks with eating disorders. And it's evidence-based, and perhaps we can touch on this later, but I would say it's evidence-based because we did a study on it, right? Like, there was no evidence-based for peer support for eating disorders because it wasn't something that interested academics that much, / a lot of them were very, very skeptical of people who had been struggling with eating disorders helping one another. But we knew, we went out and did customer interviews with our community, these 40 chapters of over 100,000 patients and families who had lived through eating disorders, and said, what was the most meaningful thing in your recovery? And without a doubt, loud and clear, the answer was people who've been there, people who understand what I'm going through, understand my brain, and can show that recovery is not only possible, but really worth fighting for. And so we built the program, we did a randomized control trial with Columbia, got back great results, and I saw that program changing lives every single day. And yet the majority of people who came to Communities of Healing didn't have outpatient providers, because what's happened in eating disorders is, one, the demand just so outpaces the supply, with 30 million Americans with eating disorders, and yet so many people, there are still entire states that have 0 eating disorder providers. Even if you call yourself an eating disorder provider, unclear whether you're actually trained in the latest evidence-based treatments, which becomes incredibly problematic. And then 3, because that demand so outpaces the supply, eating disorder providers can easily charge $250, $300 an hour out of pocket, and their wait lists are so long. And so almost all of them are out of pocket. Nobody works with insurance companies. And for an eating disorder, you don't just need one appointment a week, you need multiple appointments a week. This is an illness that really does require a multidisciplinary care team of, at the very least, a therapist, a nutritionist, and a psychiatrist. So, you know, it's hard enough to find one person. It's really, really impossible to find a full team of people. And then, you know, we're not even getting into how to get there, like logistically, right? Pre-COVID, driving around to all these appointments that may be hours away. So outpatient treatment is incredibly inaccessible, but more and more we've seen the rise of these private equity-backed residential treatment centers, as Erin was talking about. And it was always just, I knew from a gut level from a very early age from my own experience that this didn't seem to be a solution that made a whole lot of sense. I talk about, I was sick before when I was 13, I was in and out of treatment for a total of 7 months, in and out of different hospitals. I always say I was sick before the days of the fancy residentials, but still, I love treatment, right? It was like safe, it was easy, people understood me, I didn't have to deal with my triggers. The hard part was coming out and doing it in life, and it only got harder the more times I went in and out. And thankfully, when I got out, I got hooked up with a family-based treatment specialist. Family-based treatment is the leading evidence-based treatment for adolescents with eating disorders that is still so inaccessible. So thank God I was hooked up with that. And thank God when my parents said to me, Kristina, do you want to try this new family-based treatment approach, or do you want to go to residential? I wanted so badly to go to treatment. And it was the healthiest decision I ever made when I was sick to say, no, like it's only going to get harder the more times I come in and out. I have to do this in real life. And that was my path to recovery. But frankly, over the last 10 years, 15 years, it's just been horrifying to see people that I was in treatment with cycling in and out of these treatment centers, not getting better. And unfortunately, we all know that the longer a mental illness is present and untreated, the harder it does get to recovery. So it made no sense to me as this continued to accelerate, where more and more outpatient treatment was inaccessible and more, for some reason, residential treatment was accessible, right? I was running this treatment grant program where more and more I was like, it's not adding up. And so when actually Anthem had approached us about 2 years ago at Project Heal about thinking about how can we partner with you for your peer support program, it just really naturally got us into conversations where I was like, super glad you're reimbursing for peer support, absolutely part of the standard of care, and it's not enough. People need good quality outpatient treatment. Right now, that's not accessible, but you're spending a whole lot of money on treatment that doesn't work as well. And to our surprise, or maybe not surprise, they were like, we know. And actually, if you built it, we'll come. And so we got our marching orders about a year ago and started to build it.
And I really thought that these residentials were started by just really well-meaning, big-hearted people who wanted to see patients get better. And I remember entering the field 10 years ago and thinking like, oh, this was going to be the end of the residential treatment, that they're going to start closing because they're just not working. There's no data that shows that they work. We hear from former executives that 50% relapse the first time visiting. And I remember, and I think this is why you need to have clinicians and academics partner with people with lived experience. Like I remember like hearing this, but it wasn't until I met Kristina and really started talking with her about her experience that it like clicked for me when she said it was safe and easy going to treatment. And it made me realize too, so many people who suffer from eating disorders are in middle school. And I don't know how those of you watching this felt about middle school, but I am so glad that I never have to go back, right? So could you imagine being gone from middle school for like 6 weeks and then you come back and everyone wants to know where you were at? Like, that does not sound fun at all. I would like to go back to riding horses and sitting on the beach and talking with people about my triggers. So I think it really illustrated why I think it's so important to wed the people who've been treating the illness with people who've actually lived it, not just people who've had it, but also their parents as well. So I thought that residentials would start to kind of go away because they aren't working, because they aren't working. And a lot of the residentials had been opening up outpatient levels of care, and that got me kind of excited. But, money kind of drives things. And you asked why we decided to do a startup. The margins are such for the PE firms that the residentials are where the money is at. And so they've actually been closing their outpatient doors. So now for patients around the US, their options are really no treatment or go away to treatment. And there are 12-year-olds, I've seen 10-year-olds, 13-year-olds that are being told at the very first time they get diagnosed with an eating disorder to go away and live away from their family to get better. And in the end, it creates someone who identifies more with being a patient and being at a residential than identifying with being a middle schooler or a basketball player or a theater geek or whatever they are. So why startup? I never I still think that if you would have told me a year and a half ago that this is what we'd be doing, I wouldn't have believed it. You know, academia was a path that I'd been on for a really long time. I was originally a neuroimaging researcher, was really interested in the way in which our environment changes the brain. And I fell into eating disorders on accident. I was off cycle for my fellowship after giving birth to my first son. And someone told me that Walt K at the Eating Disorder Center was hiring. And I'm like, why would that interest me? And I think that's important to note, that even within the medical field, there's an incredible bias against eating disorders. So I went to school for way too long and got 0 hours of training in eating disorders. And my peers that I meet that are also dietitians, psychiatrists, same thing. You're not trained in eating disorders. And in fact, we're kind of told to just stay away from it, which is another problem we're having in our community, is that people are having a hard time finding even pediatricians that will see their kids. People don't want to take people who have eating disorders. So while Kristina was having trouble getting fundraising, and she kind of underplayed it, just to let you know how bad it is that the average mental health illness is getting $75 per patient, whereas eating disorders get 75 cents per patient. Fundraising is incredibly difficult. We've stopped blaming the victim or blaming parents when their kid has schizophrenia, when their kid has depression, but eating disorders, we still kind of blame the victim, blame the patient, blame the parents. And that has prevented not just philanthropic funding, but also research funding. So it's also the least funded from a research perspective. So this is all a long way of saying that from academia, I never thought about going to a startup, but the problems just kept piling on. And when I would talk with Kristina, she's like, nonprofit doesn't have the capital to solve this. And from my standpoint, academia didn't have the nimbleness, the flexibility, the risk tolerance to try something new. And so that's how we came about going the startup route. And so now here you've got two very financially conservative people, a nonprofit and an academic, so doing startup. Go ahead, Kristina.
I will also say it's, I think it's been really, really interesting to be in this healthcare VC community, and particularly in this behavioral health VC community. I've just found it to be so incredible, so inspiring, so many mission-driven people with backgrounds that, you know, can be similar to me and Erin, who really, really do want to solve these problems. And I think, you know, it's easy to create kind of false dichotomies. I think in the eating disorder field for a very, very long time, we vilified these insurance companies. And it was shocking to me as a, you know, young 22, 23-year-old sitting in these meetings with some of the all-stars in the field who I've admired for so long, talking about, you know, how do we create better standards for care. They've never talked to a payer. And it was just like, okay, if we're looking at broad systems level change, of course we need to be working with the payers. Of course we need to be talking to them about the problems that we see when we're thinking about really, really transforming the healthcare system. Like, this is where we are right now, and we have to be in partnership and collaboration. So I think that's been incredibly important. I'll also say that we worked really hard to find investors who really cared about the mission. I think we led first by saying, we are doing this. I've been on the same mission since I was 15 years old, which is to expand access to good quality treatment for all people with eating disorders. I just found a smarter and faster way to do it, right? But this is a mission-driven company at heart. And so we led with that when we were choosing really everybody, right? Like when I was choosing Erin, when we were choosing the first couple of folks for our team, now we have a group of 11 amazing, amazing mission-driven team members. And then investors too. Everyone has a really, really personal stake in this cause. And that was really important to us.
Mm-hmm. Yeah, that's remarkable. So I guess in that process, anything surprised you in terms of launching a startup? And
oh my gosh, everything. So one thing that has surprised me is how incredibly invigorating it is. What I've loved about the healthcare startup world is people are taking really big problems that, I guess, to be honest, in academia, we're like, this is going to take 50 years to solve, and we're going to do 14 randomized controlled trials, and then we're going to do this, we're going to do this. No, that they are taking really big problems, being like, how can we solve them now? How can we tackle them now? So I have been surprised and loving the optimism and the creativity of the healthcare startup world. It's been invigorating. The other surprise is the emotional roller coaster that happens every day, right? Like every day I have a moment where I feel pretty overwhelmed. I feel really like on top of the world and like I can do anything. I feel pretty worried. And yeah, and then I just kind of like cycle through those main emotions. Would you say that's kind of how my day goes, Chris?
Yep.
Yeah. It's incredible when you have a little bit of capital to be creative, and when you don't have the guardrails of academia being so risk averse that you can actually try some new things and think outside the box. So for instance, Kristina mentioned peer mentorship. So I think that the degrees that lots of us have gone out and received, great. But that doesn't mean that that's the only way to help someone get better, is if you have a couple letters after your name. And quite often I find that the letters after the name are a better representation of the privilege someone had than the actual ability they have to help someone. And when you're in a hospital, an academic medical center, you're really confined by the letters after your name. Only certain people can do certain things. And it's been wonderful getting to explore, like family mentorship is a huge part of what we're doing. So imagine that you are a parent who helped your child recover from an eating disorder. How much wisdom you have that you can share with other parents. People always bring their best self to sessions, right? Like I don't have tantrums at the dentist. Like I don't, like if I'm fighting with my husband, that doesn't come up when I'm like getting my hair cut, right? Like you bring your best self to your appointments. But family mentors know about like the tantrums that happen, the tears in the middle of the night, just the way in which the whole family is walking on eggshells because of the eating disorder. And so that's an example of something that we've been able to do when we can think of creative ways to help families. Because we're serving not just the patient, but their whole family. And we're using family mentors and peer mentors, as Kristina mentioned.
Yeah. I think one of my biggest learnings is actually on like product market fit. People kept being, we're learning a lot of new terms and acronyms, but people kept being like, wow, it's really incredible the product market fit you guys have. And we were just like, that's a buzz term of startups, but really recognizing that obviously that's the most important thing. And I think the reason that we have it is because we have literally each spent the last decade doing customer research, customer discovery. Really, we like intimately know and understand our patients. And for those, I think Erin and I cover a great deal of breadth, me from this, patient community, Erin from the academic and clinical community. But for example, parents are a huge part of our treatment, and neither of us parented anybody with an eating disorder yet, hopefully. So we brought on...
Sam's been a pretty picky eater through all of COVID. Oh my goodness.
Very genetic. So we brought on really the biggest rock star in the eating disorder community, who's been working with parents in the trenches, all of them have been doing free volunteer labor for years and years and years. And we said, come work with us and help us build this program. And we lean on her more than anything. And we see it when we're having product discussions, when we're talking to our engineers and they ask us a question, they feel it because they're like, wow, this is amazing. I don't have to go and spend months doing focus groups because you've spent 10 years doing them. So you really, really get it. It's cool to start a company literally of your customers.
Mm-hmm. Yeah, I just have to point out, even in our first meeting, it was refreshing, but also funny to hear you both talk about, oh, the startup world is so new to us, but like you have done so many things, so many more things that are relative to launching your startup than any entrepreneur that is, of course, does not have the background. So it's just so exciting and going to make such a huge impact for so many that you decided to take the leap. I think, Kristina, you may have mentioned earlier all stakeholders in how you were evaluating to partner with them, and tell me more about like what are good qualities of those stakeholders, and I think you may even have alluded to a stakeholder advisory board even.
Yeah. So we're officially launching Equip next month, so that's why we're being a little bit quiet about everything that we're doing, but excited to unveil it next month. But one of the things that we really wanted to do before we unveiled, and really as we're still building Equip, is bring folks in. And we're very, very cognizant of the fact that although I think we do have amazing experience, I always say like, I very much fit the mold of what people think an eating disorder sufferer would look like, that, young, white, thin, upper middle class female. The reality is that's not true at all. Eating disorders affect folks actually pretty equally across race, class, ethnicity. A third of sufferers are men. The majority of people with eating disorders are not underweight. You really cannot tell just by looking at them. And these are the people who have disproportionately been missed, been not included in research studies. I mean, we just found out a year ago, that as the level of food insecurity in a community rises, the level of bulimia and binge eating disorder directly rises. Crazy that that was just learned in our research 2 years ago. It just really reflects who's been listened to in this population. And so that was really important from the very beginning to say, we need to be directly informed by all of these stories that we're not touching, because eating disorder recovery for me looks really, really different from somebody who's on our stakeholder advisory board who's 35, gay, Black, and a man, right? Just different. And so needed to have all those voices. And because there are such diverse stories, and also we wanted patients, we wanted families, we wanted moms and dads and stepdads, right? And then similarly, we have a number of different providers in the EQUIP team. And so really bringing together providers from, I would say it's sort of been a dream of people who over the last 10 years, I have seen their work in the field and I've said, wow, this is a person that I've learned from tremendously and I want to continue to learn from. And similar to Erin, that we've been able to say, come in from the very beginning and help us build. And I think that's actually, one of the philosophies and a cultural value of ours at EQUIP that's super, super important is that we're not committed to being right and knowing all the answers at all. I always say I'm committed to hiring people who are better than me, getting the right people at the table and then letting them shine. And I think that is incredibly, incredibly important, not to go in thinking that you know everything, right? Because we definitely don't.
One of the hopes that we have right now, if you go in to get eating disorder treatment, oftentimes the people who are treating you are pretty homogenous crew. It's a lot of young, white, thin-bodied women who are working at these eating disorder centers. Well-intentioned, big-hearted, but they aren't representative of all the people who get ill. And I alluded to this earlier, that I think one of the problems in mental health in general is that we ask people to, go get your degree, become a social worker, marriage and family therapist, but then we ask you to then spend even more money to get specialized training. And for a lot of people, it was just a reach to go get that master's degree in therapy. They don't have $10,000 in 2 years to go become an eating disorder specialist. And I know that Kristina gets sick of hearing me say this, but the Container Store pays people to do 185 hours of training in their first year. And that just blew my mind when I think about how we ask, so for most master's level therapists, they pay in order to get trained even after they get their degree. And that's out of reach for many, many people. And yet at the Container Store, where they actually want you to feel like you're going to therapy when you go to the Container Store. So for anybody else who's listening to this, being like, yes, you're my people. It's a great place. But I'm like, we should do this. We shouldn't be making people pay to get trained in evidence-based treatment. We should be paying for people to do that. And that way we can go into people's communities and train them with people who've grown up in that community. So let's say you live in a community where you had some food insecurity and that resulted in getting bulimia. Do you want to be treated by someone who grew up in a radically different way than you, who doesn't look like you, who doesn't understand where you've been? No, let's go into your community and find someone who we can train to help you through it. But one of the things we see ourselves as doing is being a service not just for patients and their families, but also for clinicians. So dietitians, psychiatrists, mentors, and therapists, they've been working in hospitals where they've been really struggling under the RVU model. Most hospitals are actually designed more for cardiology and other physical medical ailments, and behavioral health is often an afterthought, and it's not always well managed. Or they've been in private practices where they feel really alone and isolated and don't get to work as part of a team. So we're excited to also be serving these big-hearted, smart people who want to help people get better by providing them with ongoing training and a team of support.
And paying peers. Because all these people have been doing very, very emotionally draining, hard work for free, and that's just not acceptable. We actually think they're going to be the secret sauce of our treatment. So we're going to compensate them to show that we believe it too.
Mm-hmm. Oh my gosh, I can't imagine how powerful that will be. I'm a huge advocate for peer support in behavioral health, and what you're doing is so novel and exciting, and in fact, for our audience, we've got everyone from health systems, health plans, other startups, investors. What you're doing is so exciting and interesting, but how can help us understand what should payers look for when looking for solutions in the eating disorder space? And surely you've talked a lot about that already, but more specifically, you've already partnered with a few payers, and can you tell us a little bit about that experience?
Yeah, I think that what payers should look for is the treatment that works. And this is an area where payers have really been handicapped, right? They've been at the mercy of saying, this residential center says we are delivering eating disorder care, and they just have to believe that that's what they're doing. And there has to be a demand for transparent sharing of data. So for instance, in eating disorder treatment, you should be gaining 1 to 3 pounds per week if you're on weight restoration. The number of eating disorder providers who aren't reporting back to the payers about what the weight gain is that's happening, that's just a really clear indication if you're making treatment goals. Another is that as we move to value-based care, it's not enough for treatment to work in the moment. It has to continue to work. It needs to have a lasting impact on that person's life, and they have to stay better. And that's something that I think payers can and should start demanding. Lastly, I think that they should look for relationships that help make the payers be closer to the patient. So one thing that's been really unfortunate about the current model is that at many of these residential centers, a representative from the residential center is the only person who talks to the payer. The payer doesn't actually get to talk to their own members. They call on behalf of the member. And just an example that I saw every single week when I was at UC San Diego, parents would call and tell me about what was happening. Their child would go away to residential because a very well-meaning aunt or school teacher or pediatrician told them, oh, you have an eating disorder, you go to residential. You have substance use, you go to residential. That's part of our cultural vernacular, right? It's in our lexicon. Nobody ever says you should go to partial hospitalization program. That's not in our vernacular. So people get sent away. During the first month, the insurance covers it because the insurance has to because of law. Payer covers it. And then the payer is getting information back. It's I don't really think that this is working. They've gained 1 pound in a month. They're still purging at the same rate. And so the payer tells the representative at the residential, we're not going to authorize another month of treatment. So you're going to have to step them down to something in their community. Let's see if we can try something else. Well, then the residential center communicates to the family, to the member, your insurance company is the devil. They aren't going to pay. If you let your child go home, they're going to die. And they're able to say things like this because eating disorders have the second highest death rate of any mental health illness after opioid abuse. And so then what happens is the families pay out of pocket. So every single family I met, and we're talking over 300 families a year for the past 10 years, had been to a residential and were having a minimum of $100,000 in debt by the time that I met them and we were using insurance to get them evidence-based treatment. And so they are blaming their insurance company for the fact that they're in debt. They're not pointing their finger at the residential. You provided treatment that didn't work. My child is still sick and I'm in debt. And who do they blame? They blame the payer. And so I think that payers need to be looking for partners that can help to strengthen the member-payer relationship and realize that it's truly in the payer's best interest to find treatment that works, right? So what the member needs, treatment that works, that's what the payer wants for them. Whereas it's not in the residential's best interest that people get better. And that's very cynical, but that is what we're seeing bear out. I don't know if you'd add anything, Kristina.
No, I would just say it's been really exciting to work with the couple of payers that we're working with as true partners. And I would say really moving towards this value-based care flexible framework. And I think for Equip, what we highlight is something that I'm sure is true across all of behavioral healthcare, which is really that our sort of informal tagline, you can't build a life worth living if you're not living life, right? We want these patients, we want to deliver the least amount of treatment that people actually need to get better and get to living their lives. And so we're, working to create these programs with payers where we're able to offer as really unlimited sessions when they need it, in the moment, in their lives, but also to have the flexibility to say, look, you guys have gained, 2 pounds a week for the last 4 weeks, and you have a concert to go to tonight, go to your concert, right? Don't cancel for a dietary session. And so really having conversations with them around, okay, here's the flexibility we need to deliver the absolute best care to patients, and everyone wins. It's been a really, really thrilling process where, look, better quality care is also more affordable care.
Wow, that's fantastic. I can't wait for your launch. I mean, really, this is, as I said before, is so refreshing, and certainly this industry really needs it. So for the folks in the audience, definitely be sure to follow up with Equip. Their team is growing. There's so much more I wish we could talk about today, but unfortunately we're out of time. So Kristina, Dr. Parks, could not appreciate this more. Thanks so much for joining me.
Thank you so much for putting this together, Salome. Looking forward to many more.
Take
Thanks
care.
so much.